Hello, my name is Dr. Chirag Shah, and I'll be presenting the poster entitled Telepsychiatry for Assessing and Managing Tardive Dyskinesia, Expert Insights from a Cross-Disciplinary Virtual Treatment Panel. Virtual medical visits in psychiatry, or telepsychiatry, are becoming increasingly useful and will likely continue beyond the current societal circumstances. Tardive dyskinesia, or TD, is a persistent and potentially disabling movement disorder associated with prolonged exposure to antipsychotics and other dopamine receptor blocking agents. Differential diagnosis and assessment of TD can be difficult during in-person visits, and evaluating TD may be even more challenging in virtual settings. To better understand how telepsychiatry may be applied to TD, insights were solicited from a panel of 12 expert healthcare practitioners. In July of 2020, 6 neurologists, 3 psychiatrists, and 3 psychiatric nurse practitioners participated in individual, semi-structured, qualitative interviews about how TD is diagnosed and treated in real-world clinical settings. After these individual interviews were completed, a virtual roundtable was held in November of 2020 to discuss how telepsychiatry can be used to diagnose, assess, and treat patients with TD. No quantitative or statistical methods were applied, and key findings from the individual interviews and group discussions are intended to be narrative in nature. The panel agreed on the following key points. Telepsychiatry visits for TD must include video. Virtual visits cannot completely replace in-person visits. Most new patients will probably require an in-person visit for evaluation and diagnosis, and if possible, all patients should have an in-office follow-up visit at least once a year. Figure 1 summarizes the potential benefits of telepsychiatry that were identified by the panel, such as less travel time and costs for patients and fewer no-show visits, as well as possible challenges, such as possible technical issues and difficulty in observing the entire body. Best practices for telepsychiatry that were identified by the panel are shown in Figure 1 and Figure 2. These include the use of video for all telepsychiatry visits, as well as patient education, development of a patient checklist, and a pre-appointment nursing check-in. Figure 3 highlights the challenges of assessing TD in virtual settings that were identified in individual interviews, including the potential for a misdiagnosis between TD, drug-induced Parkinsonism, and other tardive syndromes, which can result in using inappropriate treatments for TD, such as anticholinergics. Figure 4 shows the strategies that were provided in individual interviews for addressing these challenges, including eliciting feedback from patients and caregivers about the presence and impact of abnormal involuntary movements and providing education about the 2 approved TD medications, valbenazine and deutetrabenazine. As shown in Figure 5, telepsychiatry can be part of an overall strategy for improving TD diagnosis and treatment. In conclusion, although patients and clinicians are largely satisfied with telepsychiatry, it is not a one-size-fits-all approach, particularly for movement disorder and/or mental health patients who may require additional in-person visits. Telepsychiatry may present challenges, but virtual visits with video can be used to diagnose TD and assess changes over time. Audio-only visits may be insufficient in this population. Educating patients about their visit, providing checklists for setup, and pre-appointment check-ins can improve the telepsychiatry experience for both patients and clinicians. Clinicians might need to develop strategies to address the challenges of assessing TD in virtual settings, but telepsychiatry can be an important component of improving TD diagnosis and treatment. If you should have any additional questions on this poster, please email medinfo@neurocrin.com. Thank you.